Welcome to the JOMA Preventative Health Podcast, hosted by the Jewish Orthodox Women's Medical Association. We provide you with up-to-date information on health topics geared towards the Orthodox Jewish community. This podcast content is provided for informational purposes only and is not intended as medical advice or as a substitute for the medical advice of a physician.
Welcome to the Jewish Orthodox Women's Medical Association, or JOMA podcast. I'm your host, Elisa Minkin. I'm a general pediatrician and proud JOMA member. And today I'm really honored and really excited to be interviewing Dr. Christy Huff. Before I start, I always ask for people who have topics that they haven't heard yet or themselves want to be interviewed or know someone that they would like to be interviewed. Please reach out to me at health, HEALTH at joma.org. Also feedback, I'm very interested. So today I'm interviewing Dr. Christy Huff. She is a cardiologist and director of Benzodiazepine Information Coalition, a nonprofit that educates about the adverse effects of prescribed benzodiazepines. Dr. Huff attended medical school at the University of Texas Southwestern, where she graduated Alpha Omega Alpha. She completed an internal medicine residency at Washington University in St. Louis and a cardiology fellowship at UT Southwestern with a focus in advanced cardiovascular imaging and noninvasive cardiology. She is a fellow of the American College of Cardiology and was a private practice cardiologist in Fort Worth, Texas until 2011, when she became a stay-at-home mom after the birth of her daughter. Dr. Huff speaks and writes frequently about her lived experience with benzodiazepines. In 2015, she experienced adverse effects after 3 weeks of prescribed Xanax for insomnia. Over a 3-year period, she slowly tapered off benzodiazepines, utilizing Valium, and suffered protracted and disabling symptoms. Her personal experience led her to realize the serious risks of these medications and the potential severity of the benzodiazepine withdrawal syndrome, neither of which were emphasized during her medical training. Dr. Huff specifically advocates for better education of physicians regarding the adverse effects of benzodiazepines and how to safely taper patients off these medications. Her research interests include patient-centered benzodiazepine deprescribing and benzodiazepine-induced neurologic dysfunction, or BIND. In addition to her work at BIC, Dr. Huff is a member of the Colorado Consortium for Prescription Drug Abuse's Benzodiazepine Action Work Group. And she can be reached at www.benzoinfo.com, benzoinfo.com. Welcome, Dr. Huff. Thank you so much for joining me today.
Thank you for having me.
Oh, I really appreciate it. And I really appreciate it being on short notice. You know, I just read this book, Blood Orange Night by Melissa Bond, and I couldn't put it down. And I couldn't believe that as a physician, I had no idea about the dangers of benzodiazepines. So I'd like to start with your story, because I think that, you know, as physicians, we're hearing warnings. You know, the FDA came out with a warning like a year and a half ago about dependence on these medications and to be using them judiciously. That doesn't work the way a story does. So if you could start with your story, as much as you're willing to share, that would be amazing.
Oh, sure. So in 2015, I experienced a health crisis. I had a severe dry eye syndrome, which doesn't sound like it would be that bad, but actually extremely painful. I couldn't sleep and I was losing my vision. I was terrified. And my doctors gave me a prescription for Xanax just to help with help me sleep through the pain and also some of the anxiety I was experiencing until we could, get a plan together to help take care of my eyes. And I began to take just 0.25 milligrams at night just to sleep. I was trying to use it sparingly because I knew these drugs could potentially be addictive, although I've never had a problem with addiction. So I thought, well, as long as I'm taking this as prescribed and not too much, I'll be okay. Well, within a few weeks, I started to have some really strange symptoms. I started to have a tremor. And then I noticed that I was having a lot of worsening anxiety and my mouth was drying out. Like I couldn't be away from, drinking water for I mean, I was like drinking water every 5 minutes, and I was getting sicker and sicker. And I went to my doctors, and they thought, well, maybe this is some autoimmune condition or a neurological condition that's kind of tied in with the dry eye syndrome. And I went through this extensive medical evaluation, and I just continued to get sicker and sicker, and all the tests came back normal. And it got to the point where every few hours I started to have these intense symptoms where I would be shaking and I'd have difficulty breathing. And I started taking more Xanax just to help with the increased anxiety I was experiencing, and still never exceeded the prescribed dose. And eventually my providers just said, well, you're having a mental health condition, since we can't find anything wrong with you, it's just anxiety. And one day I was asked to hold Xanax for a test. Just don't take it for the next 12 hours. And I went into basically florid withdrawal. It was like an elephant was sitting on my chest. I was shaking all over. And as soon as I took a Xanax, all those symptoms melted away. And I thought, this must be the problem. So I got online and I found a website called Benzo Buddies, which is a site for people withdrawing from benzodiazepines. And everything I read there sounded exactly like what I was experiencing. I'd become physically dependent on Xanax, and I was experiencing something called interdose withdrawal, where I was having withdrawal symptoms in between doses of Xanax. It wasn't lasting maybe but a couple of hours for me at this point. And so, after that, I ended up coming back to the doctor who prescribed it, and they told me, well, there's no way you could be dependent on it. You've just been on it a few weeks. And I asked them to help me with a taper plan. And I went through several different doctors trying to help me find a plan to taper off the medication.
What did they tell you to do originally?
What's that?
What did they tell you to do originally? How did they tell you to get off it?
Yeah, so originally my primary care provider's office, they said, basically you can just stop it, but if you really want to do a taper, you can get off in 2 or 3 weeks. Because I begged them, I was like, I need to taper, and actually showed her a copy of the Ashton manual that I had found on Benzo Buddies. And Ashton's plan says you should switch over to a long half-life benzodiazepine like Valium to taper off to help cover some of those interdose symptoms. And I asked her about switching to Valium, and she was like, why would you want to, go on to another benzo? You're already on Xanax.
You know what? Can you stop for just a minute and explain what the different kinds of benzodiazepines are? I think that's a really important point. You were on Xanax, which is one of the most shortest acting.
Yeah, Xanax is very short acting and very potent. And there's also Ativan, which is short acting, clonazepam, which is one of the higher potency, but also a little bit longer acting. And then finally, Valium, which is lower potency, but much longer acting. And I think those 4 are the most commonly prescribed benzodiazepines in the US. But yeah, they differ in half-life, and with the short-acting benzos, like I said, you can get these symptoms of interdose withdrawal. It's like you have these peaks and valleys in the blood levels of the drug, whereas with a longer-acting medication like Valium, the blood levels remain more steady throughout the day, and it's kind of like when you're trying to taper off, it's much smoother ride on the way down.
Why are they using short-acting benzos if they have a greater potential for dependence and interdose withdrawal? Why wouldn't they just go straight to Valium?
Yeah, so I think there's a number of reasons. Valium kind of got a bad rap in the 70s, when they had the Kennedy hearings, and so the drug companies just came out and marketed newer short-acting benzos, and they do have some advantages in the sense of, like older people that can't metabolize benzos as well. It's maybe better to have a short-acting benzo on board so their cognitive and, psychomotor function are not impaired. So, there's definitely, I think, reasons that they're prescribed, but
wait a minute, just stop for just a second. Yeah. About the elderly and benzos, I interviewed a specialist who works with the elderly on their cognition, and she does not stop talking about the danger of benzos in general in this population.
Right.
So I don't want to come across as, oh, the short-acting benzos are fine, right?
Oh, no, not at all. That's not what I meant. I'm just saying that's why typically maybe doctors would lean towards prescribing those medications, just thinking that it's better to have a short-acting on board, and in that case where they're not metabolizing it as well. But with all that being said, all the benzos carry similar adverse effects. It's just that some of them differ in their pharmacologic effects as far as, half-life.
Mm-hmm. Right, because before I forget, I want to make sure that we cover that for the elderly, both any benzodiazepine and anticholinergics can actually lead to worsening dementia. And so, I think some, medical care, HCPs are thinking, well, they're old and we should just give them the best quality of life, and that can worsen it. So I think that that's really important point in that population. So I just don't want to forget to point that out.
Oh, for sure.
Yeah. Okay, so back to your story. Then what? You were looking at the Ashton Manual, which is a really good resource, by the way, and it's available on the website benzoinfo.org.
Benzodiazepine.info.com. Yes, we have a free copy of the Ashton Manual available there, and it's a good guide. It's got protocols for tapering off benzodiazepines, so. It took me a couple of healthcare providers before I was able to find somebody that would listen to me and, help me get switched over to the Valium and get onto a taper plan. And then once I did that, I was on my way, or so I thought. I thought, well, okay, I'm going to get transitioned to that Valium and I'll be off in a few months, because I really had no cravings for the drug. All I wanted was to be off of it, because I had already realized at this point I was never going to feel better until I was completely off the medication. Well, so I reduced 1 milligram. I ended up on 15 milligrams of Valium. That's where I stabilized at. And I cut 1 milligram according to the plan in the Ashton Manual. And I went into just florid withdrawal symptoms. I had, bad nausea. I mean, the symptoms just go on. And it was like almost catastrophic. And I kind of knew at that moment this was going to be a long road. I wasn't going to be able to just come off of it quickly in the matter of a few months. And so it actually took me over 3 years to taper off that 15 milligrams of Valium. And I went slowly the whole time. I first started out using what we call a cut and hold method in the groups. It's, similar to Ashton, but I was actually making even smaller reductions than she recommends in her manual. I just cut a certain amount of the dose and then hold it for a few weeks until I stabilized, and then get ready to cut again. And then about halfway through, I transitioned to a technique called microtaper, which is an off-label approach, but I was able to use a precision scale to get much smaller reductions of the medication. And that was definitely helpful in that it just kind of smoothed out the withdrawal symptoms and made things less intense for me. But it was still a rough ride the whole way down. And then, at the end of the taper, my body was a wreck. My health was, my life was just, it was just a mess, and I had, severe muscle weakness. I had been in bed for, months towards the end of the taper. And so I just spent a lot of time putting my life and health back together. And it took me about a full year, I think, afterwards to get back to normal. And, even I'm over 3 years off now, and I still do have symptoms that I struggle with that are related to coming off the benzodiazepine. I'm functional, but I still have times where I get tired and I have to, pace myself and, set up boundaries because I still can't tolerate stress to the same degree that I could before all this happened.
This is a hard question, but how do you know that that's from the benzodiazepines and not underlying anxiety? I know that's a hard question, but it's something I'm trying to understand about this.
Yeah. So, I would say that it's because I developed a whole bunch of new symptoms that were not even related to anxiety. Like, I mean, one of the symptoms I still have is like this internal tremor or kind of buzzing sensation, and it gets worse when I'm stressed. And that's not something that's really caused by anxiety. And also like severe fatigue. It's just a lot of physical symptoms and things that I didn't really have before I started the drug. And then, when I was tapering off as well, every time I would reduce the dose, I would get this barrage of withdrawal symptoms. And it was very obvious. I mean, it was like clockwork. I wrote things down on a calendar, and it was like, okay, at day 4, you're going to start having this symptom. And at day 8, this is going to pop up. And so it was really it was pretty obvious when I was experiencing it.
Listening to you, and this is just incredible. And, these are heroic efforts. I mean, I hear your story. I heard the story of other people and Melissa Bonds, and you guys are just heroes. And I think you're unsung heroes, because I don't think so many people understand. I know I didn't, right? Including physicians. And I'm wondering whether you hear stories of people who go to physicians who are dismissive of all this.
Oh, but certainly that happens all the time. It seems like the knee-jerk reaction for the physician a lot of times is just to, call the patient an addict and saying, you need to go to detox or rehab, or we just need to stop this medication really quickly and get you off of it because you have an addiction problem. And, that's not the case. Most of these patients, like me, just purely have physical dependence. Our bodies have adapted to being on the drug, and we need to be taken off of it slowly. And yeah, the patients that are experiencing these protracted symptoms, even months and years off the drug, it's not on the doctor's differential or so it's like they don't exist in a way, and they just say this is anxiety or some other medical condition, or just we don't know why you're having all these symptoms.
Right. I've heard of people being worked up for MS and other neurologic conditions based on these symptoms.
Oh yeah. Well, yeah, and I went through that exactly. I had a huge battery of tests. I had a lumbar puncture MRI. I mean, it's just the workup was huge, and it was a large amount of money that I spent. And I heard of other people doing it. I mean, I've heard stories where, people will get this extreme dental pain, it's nerve pain, and people will have teeth pulled when there was nothing wrong. So and I know a lady that had, she had brain surgery because she had a little, small tumor on her pituitary gland that I don't think needed to be treated, but they were assuming that she had, severe headache, and they're like, we need to do this surgery, and it didn't correct the problem. So it gets obviously very confusing. And then if you don't put that on your differential diagnosis, then, the physicians, they're just not going to see it.
Right. I'm also wondering how much of the time the withdrawal is confused with an anxiety disorder, because it's ironic how going off it makes you so profoundly anxious.
Yeah, I think that's the most common thing that happens. Because benzos actually have been shown to make anxiety worse in the long term. I've heard it termed, benzodiazepine-induced hyperanxiogenesis. That's a mouthful, but
one way of saying you feel more anxious when you're on them, which is ironic because they're prescribed often for anxiety.
Yeah, and that I definitely experienced that. I mean, I'm a type A person. I've experienced anxiety in my life, but what I experienced on benzos, I mean, it doesn't even compare. It was like this kind of man-eating terror, like a bear is coming after you, but it was almost 24/7. It was just so intense and almost like not something that my brain could have even generated on its own.
I have a question. How many people who take benzodiazepines will get this dependence/withdrawal problem? Not everybody, clearly. Or we'd hear about it more, right?
Yeah, I think the statistics are kind of all over the place. The APA task force in 1991, they said estimated on their review of studies between 40 to 80% of people will have withdrawal symptoms coming off. Ashton, in her manual, she says, people coming off long-term benzos, 10 to 15% are going to have these long-term protracted symptoms like I'm talking about. And then there's there's the class of people, maybe it's half, I don't know, but they can just easily walk off benzodiazepines, no problem. And then it kind of makes the rest of us that struggle to come off look like, we have a problem. So and it's kind of hard
being, labeled the, mentally ill patient, the psych one.
Yeah. I mean, we kind of face stigma from multiple fronts, like either we're mentally ill or we're suffering from addiction or, and that's just, not the case in this patient population.
Right. This organization is just for people who've been prescribed benzodiazepines as opposed to use them as part of a substance use abuse picture, correct?
Yeah. In general, that's the population that we're representing. I mean, it's not like we would turn anybody away, but it just seems like there's differences in, those populations. And the FDA actually even noted that in their box warning that most of the people that are having addiction with benzodiazepines are the ones that are using them with other substances like opioids and alcohol. And the average patient who's just taking them prescribed from their doctor, they're the ones that are dealing with the physical dependence alone.
Can you define addiction versus physical dependence? Because I know it's on your website that language really matters. It's not even about stigma. People think, oh, that's about stigma, but it's not. Yeah.
So physical dependence is just basically the body's physiologic response to taking a benzodiazepine. And so the brain, the body adapt over time to the presence of the drug. And then when the drug is reduced or removed, then you're going to get withdrawal symptoms. And addiction kind of you can be physically dependent and addicted at the same time, but people with addiction, they have the cravings and compulsions to take the drug. And so there's definitely a difference there. And there's definitely a difference in the way that you treat it. I was just going to say, for physical dependence, we talked about a gradual taper is the best way to come off, to just give your brain and body a chance to adapt to coming off the drug. And then, those patients aren't going to necessarily benefit from detox and rehab, where they take you quickly off the drug, and they won't necessarily benefit from the 12-step model. So really, I think it's important to make the distinction because there's a difference in how you treat these patients.
Absolutely. And, you mentioned that you were off for 12 hours and went into Florida withdrawal, and how it took you years to get off them. So clearly detox/inpatient rehab is not going to work for that. It could be dangerous, correct?
Yeah, it's definitely dangerous. And I've known people that were taken off the drugs very quickly, and then they experienced long-term injury just because their brains weren't given a chance to adapt to being without the drug. So it's like a big shock for the brain and body to come off of it so quickly.
Can you go into more what happens when you take benzodiazepines in terms of what it does to the brain?
Yeah. I mean, it depends on the person. So not everybody's going to be physically dependent. But I think in the population of people that become dependent, scientists think that the GABA receptors, because these drugs bind at the level of the GABA receptor and enhance the neurotransmitter GABA in the brain. So they, losing my train of thought,
it's the feel-good hormone. I've heard.
Yeah, exactly. It's the inhibitory neurotransmitter.
Right.
But over time, with use of these drugs, you can get down regulation of the GABA receptors. And there's even theories that maybe you can also get altered conformation of the GABA receptors. And, maybe things don't completely go back to the way that they were after you're completely off the medication. And so there's a thought that maybe some patients have permanent effects in their nervous system after they come off the drug.
And I presume that all of these would be related to the length of time that you're on it.
Yeah, I think that's what the literature says. Now, they say higher doses and higher length of time on the medication means you're more likely to become dependent. But if you look at the FDA adverse events database, some people are reporting becoming dependent within a matter of days. And so physical dependence can happen very quickly. And, in my case, I started to have symptoms within a few weeks on the drug. And then it took me obviously years to come off. And I've met other people like me that, some people, it takes a while before they start to have issues with the benzodiazepines and develop, tolerance and other adverse effects. And then I've met others like me that it all just started very quickly.
Would that be related to the shortness of acting? Like, in the book, the Blood Orange Night book, Melissa was given Ativan, which is also short acting. You were given Xanax, which is short acting. Is that a major factor or not always?
I've postulated that it is, but I guess I don't really have any proof of that. But I do think because like Xanax in particular is, very short acting and very potent. And it seems like people can get into trouble with that pretty quickly. Just because of the nature of the drug. Whereas, people that are on like clonazepam or Valium, maybe they're not going to notice tolerance symptoms until, months on down the road. Some of them, they'll notice for years.
So, these drugs are there, they work, and they're very valuable, right? We're not talking about throwing them out. What do you think is an appropriate use of these medication? Because I don't get people to come out with this. These are toxic. No one should ever touch them with a 10-foot pole. And then were they to need them to be turning them away?
Yeah, no, I think they're good to have in the short term. Like, for instance, I use them for fear of flying. For years, I would just take one dose on the airplane, and I maybe used it once or twice a year, and that seemed like an appropriate use of it. And I never have any problems with that. So I think for like very short term situational anxiety, and then times when it's not going to be used for more than 2 to 4 weeks. And
but wait, you got dependent in 3. Wait.
Well, that's and I think the 2 to 4 weeks is what the FDA will tell you. But I personally would err on the side of caution. And I personally am never going to take another benzodiazepine again after what I went through. But I think the option obviously needs to be available for people. There just need to be options, but people need to have informed consent.
Exactly.
And know, like,
upfront, right? The risks and benefits.
Yeah. Like what are you getting into before you, sign up for this prescription? And then, after you've heard all the risk and benefits, then it's up to you to decide. But yeah, I would say very short term use, and they're definitely important, like in the emergency room setting for, acute seizure, alcohol withdrawal. They're important for, sedation, for procedures and things like that. So we definitely still need them around. It's just, we need a lot more awareness especially about long-term use.
Right. And I think it's important for patients to be aware, but I think it's super, super important for healthcare professionals to be aware because, someone who's coming in, who's suffering is so vulnerable. You can say informed consent, but when you are a hot mess, how can you do that?
And I agree with that wholeheartedly. Like the physician definitely needs to be educated on these issues, because I fell into the same situation where I was just incredibly vulnerable and sick, and I didn't know which way was up. When I was, undergoing all those problems, and, not one physician actually recognized that I was experiencing the adverse effects of Xanax. And I had to figure that out on the internet while I was sick and scared. And it was just incredibly difficult. So yeah, I think physicians being educated would go a long way, towards helping out these patients.
Right. And really cautious, judicious, risk-benefit balancing use of the medications, not throwing the baby out with the bathwater. Right. But there's so many other tools we have. We don't just have benzos. I'm curious about your thoughts on the Z drug category, because those are not exactly benzos, and they're also used for insomnia.
Yeah, that's a very good question. And a lot of times we just forget to talk about them, but they actually, what we're seeing in our advocacy organization, that they generally have the same effects as benzos. They're called non-benzodiazepines, but they still act at the GABA receptors. They have similar adverse effects. We see people develop physical dependence and withdrawal. And, if you look in the Ashton manual, she actually recommends, say you have become dependent on Ambien, she recommends switching over to Valium to taper off. So
Wow.
they're very similar and have the same issues.
I'm going to give a shout out to Daron Lazarus. Daron Lazarus is a sleep coach who I interviewed. It's called A Good Night's Sleep. I'll send you the link later. And he had a Ambien dependence for his insomnia. And then he created a more holistic integrative program. And I think it's really interesting. I think it's unique. I'm not getting paid for this. It's not a paid advertisement. And it is a private paid, type program. It does not take insurance. But I think we are really struggling right now because, you're an internist. I'm a pediatrician. We get 15-minute at most intervals with our patients. And it's really hard. It's really hard to listen and get the whole picture and provide a, holistic, multidisciplinary approach in that short time. And it's much easier to give a prescription. Right. Yeah. So I think I want to give some empathy to all the healthcare professionals out there that are dealing with this situation. You just want to help, right? You're not part of big pharma when you prescribe these medications.
Right. Yeah. It's certainly a huge problem. But it's almost like you're prescribing a Band-Aid though, that, right. And, some of these long-term issues just, it's just not helping work, I guess, on the underlying problem. But yeah, I feel for the doctors who only have a few minutes with the patients, and the system is set up against them in many ways.
Do you find people don't believe you in the medical world? The reason I'm saying this is I actually read one of your pieces on Kevin MD. Uh-huh. I violated the rule of don't read the comment section. And there was apparently a doctor saying, that's just an anecdote. I need data.
Oh my gosh, that guy, we actually, he showed up on a couple of my pieces with the anecdote thing. And it's kind of funny because it's, and our thought about that is like, okay, how many anecdotes do we need to have before we start taking this seriously? It's like, yes, it's not a regimented scientific study, but we have all these patients saying, hey, this is a problem. This happened to me. And so it's because it's not just my story and it's not just Melissa's. If you go on to BenzoBuddy, I mean, there's, tens of thousands of people there struggling to come off the medication and struggling with adverse effects. So yeah, I mean, but he is right in the sense that we definitely need more structured research into this. And I'm hoping that will come in the future. But at this point, it feels like we're just trying to raise awareness about the problem to begin with.
Right. I mean, there is increasing information on UpToDate, which is a evidence-based site that physicians use. There is a section on prolonged withdrawal. There's a section on benzodiazepine-induced neurologic dysfunction or bind, which I think you kind of alluded to before, when you go off it and you still have dysfunction, which I'm sure is a spectrum from mild to severe.
Oh, yeah, definitely. We see patients anywhere from, mild to severe. And again, I wish I had the research data to say, X% of patients suffer this, and this is how bad it is, and this is their long-term prognosis. But unfortunately, we don't have that yet.
But it's clearly not 1 in a million. You're not talking about a rare adverse effect here.
No, I don't think it's rare at all. What we're seeing.
Right, but for somehow I feel like there's two worlds. There's the worlds of the benzo buddies, and then there's the medical world, and they're not really meshing, because if you look on that same UpToDate site, when they talk about going on a taper, they're like, cut it in 50% and then cut it in 25% and do it in 2 weeks. And that's not what I'm hearing works for people.
Yeah. I mean, you're right that there's a lot of knowledge in the groups about tapering, and that's actually how I learned to taper. And I mean, what we know is that people that are told to taper with these big 50% reductions and at fixed rate and just keep cutting, I mean, they don't do as well as people that are allowed to do a more patient-centered taper, where you can take smaller reductions and adjust the rate based on the symptoms you're having. And unfortunately, I just don't think doctors have gotten the message out yet, because I think, like we talked about, again, they just kind of go back to the addiction story, or, the symptoms you're having are related to anxiety or mental illness, and it's not withdrawal. So I guess they're not really, motivated to adjust the taper rate based on the symptoms the patient's having.
This goes back to the whole problem with not appreciating mind, body, and mental health, but that's a whole separate rabbit hole that I keep going down. I'm not going to go down it right here, but it's a huge problem. I don't deal with that psych stuff, with that psych stuff. But I have to say, I'm a big believer. I'm a parent of a young adult with special needs. I don't have personal experience with any kind of drugs, but myself, or in my family, so this is all new to me. But I can really appreciate how much you can learn from people in your same, situation, from support groups. I became the support group queen, and I joined every possible support group related to my daughter, because they will know things that your doctor won't know.
Yeah, no, that's very true. And I'm glad you had that experience. And it's kind of an interesting experience being a physician with medical knowledge in one of those support groups, because you also see a lot of stuff that's like, okay, this is just wrong. And so you got to be really discerning. Right. But then on the other hand, it was very helpful because I found people that were going through the exact same thing, and people that there were people in there that just taught me how to taper. Like, this is how much you need to reduce. This is how you need to do it. And finally, after reading all the information, I was able to synthesize it and kind of figure out what worked for me. And then I found friends on there going through the same thing. And I think eventually the support groups kind of got overwhelming and triggering, just because there was so much like negativity and things like that. And so a lot of us just kind of took things offline. We just exchanged phone numbers and text or call each other. And so, I found some really good friends that way, all over the country that helped me through this process.
Right. Support, validation, information. This is all critical. So how do people find healthcare professionals who know about this?
Yeah, that's a very good question. It's something that I would say that's the top email that we get at BIC. Somebody's looking for a doctor to help them taper off the medication. BIC actually keeps a list. So it's on benzoinfo.com under our resources page. We call them benzodiazepine cooperative doctors, because there's doctors that will help you with a taper. They may or may not be experts on tapering, but at least they'll maintain a prescription and let you taper as long as
they won't cut you off labeling you an addict.
Exactly. And let you taper as long as you need to. So, and we're always looking for other doctors to add to the list.
This is the Benzodiazepine Information Coalition. Did you start this organization?
No, I actually joined it a couple of years after it was started. It was started in 2016 by a group of patients harmed by benzodiazepines, and one of their directors stepped down, and I think it was in later 2017, and I took over the role after that. And so, but yeah, I've been with them since 2017.
And you're the director now?
Yeah, there's 3 directors. I'm one of them. I'm the medical director.
Okay, but that's really amazing. Do we have any way of knowing who will be in that vulnerable group? Since we're saying it's not everybody, do we have any way of knowing? Could you say this is not an addictive, but a dependent vulnerable person?
That's a very good question. Again, the literature goes back to length of use and higher dose, but I don't think that tells the whole story. And I really just don't think that we know. And it seems it can be with any benzodiazepine. It's not just the short-acting benzodiazepines. It's all of them. So I postulated maybe there's something genetic as to how these affect the body. And so this is, where we need further research to help us out.
Right. But while we're waiting for research, which can take decades, we need this awareness. And that the Z drugs, which includes Zolpidem, which is Ambien. I know it's confusing because Ambien begins with the letter A. But, I feel like first we had barbiturates, and then we realized, there's a problem with them. And then we came out with the benzos, and now we're realizing there's a problem with them. And now we have the Z drugs, which there's also a problem. Right?
Yeah. It's I think the big advantage of benzos over barbiturates is that you didn't die, and it's almost impossible to overdose with them when you're just taking a benzo alone versus the barbiturate. But but they obviously come with all of these other adverse effects that kind of, I guess they're really only looking at the statistic of mortality, but the morbidity of these things is huge. So,
it's so interesting that you say that, because one of the things that really struck me in the book Blood Orange Night is the scene when she gets interviewed for, I think it was Good Morning America, and they didn't show it. And then Philip Seymour Hoffman died of a heroin overdose, and that they went on about. And he actually had benzos in his blood as well.
Yeah. Yeah, they're sneaky. They're in, I think, at least 30% of the opioid overdose deaths because they potentiate the effect of.
Potentiate it. So that's also really important when you're looking at the substance use abuse population about the benzos.
Yeah.
But also the point that she made was that the needle in the arm, like that's what gets people. That's what people can respond to, or the opioid deaths. I mean, people are very aware, and it's a terrible crisis. I'm not minimizing it at all. But there's this other epidemic that's like more silent.
Yeah, no, it's horrible. And I just think it's easy to look at deaths. I mean, that's a very concrete thing. But then when you have these patients that are affected with bind, that are tapering for years and bedbound and, stuck in their own homes and basically missing from society, I guess that seems less dramatic. Although after having gone through it, to me, it's much more so.
It's sad that you have to go through it to understand it.
Yeah, it's.
What message would you give to physicians who have been prescribing these? Because I don't want people to listen and say, okay, well, it happens to a rare, percent of people, and I'm just, not going to, this is anecdotal.
Yeah, I mean, so I would say that this bind or benzo-induced neurological dysfunction is very real. It happens in a not small percentage of patients. Ashton says 10 to 15%. One day we'll get hopefully more hard numbers. But given that millions of people take a benzodiazepine, even if it's, just 10 to 15%, that's still a large number of people that, are experiencing these adverse effects. And I mean, we're talking of disabling effects, people's life changed forever. I was certainly disabled for a span of years, and my life is still not the same. So I would definitely say keep that adverse effect on your radar screen. I think it's really important. The gradual patient-centered tapering versus forcing patients to taper at a fixed rate or even cutting them off, because we know cutting them off abruptly can actually result in seizures and even death. So that's extremely dangerous. And as far as prescribing, again, benzos do have their uses, but I think it's always good to keep it in the short term and, look for alternatives to these medications, because there's definitely alternatives out there. And, lastly, patients need to be getting adequate informed consent about the risk and benefits from their prescriber before they even take a prescription.
Right. And can you talk a little bit about the warning that we have now? I think it was September 2020, so it's pretty recent.
Yeah. So the FDA came out with an update to the boxed warning in September of 2020. There was actually a boxed warning in 2016 for the combination of benzos and opioids. Mm-hmm. And then they updated it to talk about the serious risk of addiction, abuse, physical dependence, and withdrawal. And again, what they found is the addiction and abuse side of things is more in the context of polysubstance use. And then patients that are experiencing just purely physical dependence and withdrawal reactions are more in that as prescribed patient population. And, in talking to some, members of the FDA, they said all of these effects that they, were documenting in this label it's stuff that's really been known for years, but they just really wanted to get the warnings updated and out there so that we would have this knowledge and be really to just standardize the warning labels across the drug class. And then, what I also thought was interesting is that they did note the existence of this protracted withdrawal syndrome. If you read in the warning label, it sounds like it's rare, and there's not really a note of actually how common it is, but they just said that this syndrome can last 12 months or more. So, that is documented now in the FDA literature.
Right, but without data on how often it occurs, right, that's still going to impact how physicians look at these medications, right? I mean, if they think it's rare, they're going to look at it one way. If they're going to see it as relatively common, another way. Right? When you give informed consent, you have to put perspective on what those risks are.
Yeah, I agree. And so I was happy in one sense to see that they were talking about protracted withdrawal on the label, but sad to see that that was rare. But I'm hoping one day we'll have the information to back that up.
Right. And I think it's really helpful for physicians to give your organizations information and I don't know if they'd be comfortable with benzo buddies, but certainly, your organization, which is Benzodiazepine Information Coalition, or benzoinfo.com. I'm going to say that again, because I think it's an amazing website with information for physicians, information for regular lay people. And I think knowledge is power. Right? I mean, that can be part of informed consent. Like maybe right now you're really upset and you just want to feel better, but I want you to have this, put this in your pocket and take this home. And when you're feeling better, start reaching out because I don't want you to have these adverse effects, right?
Yes.
So I think that there are things we can do because I do feel for the physicians who have these drugs at their fingertips. They are seeing a patient who needs it right now, right? And they have 10 minutes or 5, right?
Mm-hmm. Yeah, I agree. And actually, now that you're saying that, it's got me thinking. I actually wrote an informed consent form. It's on the BIC website, and it's actually well referenced as well. But it's basically got all of the risks that I wish I had been warned about before starting a benzodiazepine. And so it's in a PDF form. You can just print it out and give it to your patients and they can look over it.
Yeah, so, I'm going to be difficult. I'll tell you why. Because you have an anxious patient and then you hand them that. They're like, I can't do this. This is too dangerous. And then you're left with this, anxious patient that you haven't helped. And unfortunately, mental health has been dumped on the primary care because we don't have parity in mental health. We don't have adequate mental health professionals, right? It's not covered by insurance. Could go on and on and on. And COVID has just ramped up the anxiety through the roof. So I'm just wondering what it's like for these, adult healthcare professionals. I do pediatrics, so I don't have as much of an issue, not nearly as much. Like I don't prescribe these.
Yeah, I mean, honestly, I can't imagine, and I know it's a tough situation, but it's just, I think another tool at your disposal to use in clinical practice, and at least have something written out there for the patient to look at. And maybe the answer is that people shouldn't be making snap decisions about when they're under duress about starting these medications.
Right, or they might need it for the very short term. But see, this is where I think that we really need a multidisciplinary approach. And sadly, we don't work like that in a lot of medical areas. Some areas are fortunate. They do have multidisciplinary programs. They have a social worker or a psychologist available at that same site. It's integrated in. But for most of us, we're on our own, and these patients come in with their multifaceted complaints, and it's overwhelming. It's really overwhelming. And I want to come up with some practical things that physicians, other healthcare professionals can do.
Yeah.
Like, what can they do? I don't know. I mean, I would work with whatever professional they could afford, whether it's a mental health counselor, if you know of a chiropractor that you trust, or an acupuncturist or any other kind of alternative person who might be able to spend more time with them, right, and support them and help them through their crisis and just using a drug.
Yeah, no, I agree. It's a difficult problem. And it seems like, I mean, at least in my area, accessing mental health care is only for the affluent because, when I was looking around for a psychiatrist to help me taper off the medication, everything was either they weren't taking new patients because they didn't really have to, and they didn't take insurance. So everything's out of pocket. And it was like hundreds of dollars for a visit. So yeah, I mean, I feel for the patients and the primary care providers both, because they just don't have access to mental health care. And the same thing for seeing a counselor or a psychologist, that was all out of pocket as well.
No, I mean, we need people to go out there and fight for parity, fight for access. Telehealth is something from the COVID that's actually a silver lining. It can really increase access.
Mm-hmm.
My own daughter is going to be seeing a telehealth psychiatrist from another state that can do psychiatry in New York as well, where I live. So that really broadens my ability to find someone. It was hard just for me to find for my own daughter to pay out of pocket, right? I mean, it's a huge problem. I don't have all the answers, and like I said, I do feel for the HCPs who are really struggling with this. But I do think that you have to be aware. I labeled this talk. I titled it "First, Do No Harm," because you may, with the best of intentions, ruin someone's life with a prescription for this.
Mm-hmm.
Right? Yeah. So I think we talked about a lot of things. We mentioned your organization, benzoinfo.com. I think that's a really amazing resource. Anything else you want to add?
No, I think we've been pretty thorough here. I'll probably think of something as soon as we get off here, but no, I think we're good.
Right. This is really a no shame, no blame for both, people who are taking these medications and for the healthcare professionals who, are using them or prescribing them. We need to be more aware. We have to know the risks and benefits and be very, very judicious. And there is information on your website about the tapers, about benzo friendly, was it benzo cooperative?
Benzodiazepine cooperative. That's another one of those mouthfuls. We used to say benzo-wise, but not everybody on our list was extremely knowledgeable about a taper. It's just, so we kind of just say anybody that will let a patient taper as long as they need to. So we came up with the term cooperative.
Right. It's an incredibly challenging problem, and I can't imagine what it would be like to be in that situation and not have a healthcare professional to work with. So that's such
a scary thing for patients. And I mean, I went through that for a few weeks myself before I found someone, and I was just terrified. I wasn't gonna, because it really was a life or death thing. Like if I didn't have the medication, my body would have shut down.
Right. And understanding that is really important for our healthcare professionals. And you can always be on the road to healing with your patient, right? You don't have to know everything, but I think the support and helping them with resources is huge.
Mm-hmm. For sure.
So thank you so much for doing this with me. I really appreciate it.
Yeah, thank you. It's always good to talk about this.
You too. Thank you so much.
Thanks for listening to the JOMA Preventative Health Podcast. If you've enjoyed this, please rate and review us on Apple Podcasts and share this with your friends. For more information, check out our Instagram at JOMA_org. Check out our website, www.joma.org, that's JOWMA.org, or email us at health@joma.org.